Welcome back to the channel. Today, we're diving into an important topic: how to approach patients with erectile dysfunction, or ED. Now, I know this can be a sensitive subject, but it's something we as healthcare professionals need to handle with care and precision. So, let's break it down step by step, and don't worry, I'll make it as interesting as possible. All right, so you have a patient coming in with complaints of erectile dysfunction. The first thing we need to do is ask about their sexual desire. This is key. You might ask something like, "Do you still feel desire for your partner?" If the answer is yes, that's a good sign. It suggests that their testosterone levels are likely normal, since testosterone plays a big role in sexual desire. Next, we ask about morning erections. If they still experience regular morning erections and have intact desire, this typically points to a psychological cause for the ED. The problem might be related to stress, anxiety, or even issues within the relationship, anything that could affect the mind rather than the body. In these cases, the cause is usually not organic. But what if the patient says they have desire but no morning erections? Well, that could be a sign of an organic issue. Conditions like diabetes, dyslipidemia, or certain medications like beta blockers can interfere with erectile function. In these cases, further investigation is needed to get to the root of the problem. Now let's shift gears. What if the patient reports no sexual desire at all? This is when we start thinking about low testosterone levels. And low testosterone comes with some telltale signs you might notice: hair loss or less frequent shaving, fatigue, decreased muscle mass, low mood, even symptoms like osteoporosis or low semen volume. In these cases, you'll want to run hormone tests. We're looking at total and free testosterone, along with LH and sometimes FSH. If the testosterone levels come back low and both FSH and LH are also low, it points to a pituitary cause. This is where things get interesting. Some potential pituitary causes include panhypopituitarism, Kalman syndrome, which can cause an impaired sense of smell, by the way, prolactinoma, or even hemochromatosis. If you suspect pituitary problems, depending on the patient's symptoms, you might order an MRI to look for a tumor or check transferrin saturation if you suspect hemochromatosis. The important thing is to investigate further if there's evidence pointing in that direction. On the other hand, if testosterone is low but LH and FSH are high, this indicates a testicular cause. So now we're looking at potential issues with the testes themselves. You'd want to conduct a testicular ultrasound and consider genetic testing to rule out conditions like Klinefelter syndrome. So you see, not every patient with ED is going to benefit from simply handing them a prescription for sildenafil. We need to look deeper, investigate thoroughly, and treat the underlying cause, whether it's related to the mind, the hormones, or the organs involved. So, that's a quick overview of how we approach patients with erectile dysfunction. It's all about asking the right questions, following the clues, and tailoring treatment to the individual. If you found this video helpful, don't forget to like, subscribe, and hit that notification bell so you never miss a video from us.